As we know that alpha-1 antitrypsin deficiency is inherent diseases, and this protein is very important in the body, and with protease, anti-protease activities, as many biological process is very important for many biological process, and this protein is coded in gene SEPINA1 in chromosome 14, and if there are mutations, nucleotides, the mutations in caused by the A1AT variants. Up to now, they found that about 120 variants. Among those, the 30 of those relating to the disease. So we see this accumulation of this polymers in this liver cells, so it causes inflammatory reactions, and it causes cirrhosis, and so at the same time, alpha-1 AT reductions cause reductions in the serum levels, and the function of this also changes. It cannot can cause imbalance between the protease and anti-protease, and cause other disease like in lungs, skin, and blood vessels. This is the pathophysiology of A1AT deficiency. This abnormal alpha-1 AT with polymerizations and cause polymerizations in the liver cells and cause liver disease, and with alpha-1 antitrypsin deficiencies cause a problem in the lungs called like emphysemas, and the other system in the body also affected by this deficiencies. For clinical manifestations, due to the pathophysiologies of accumulations of the polymers in the cells, so the clinical manifestation is very diverse, and we do not have the difference between the cirrhosis due to the antitrypsin deficiency versus other causes. So it's very difficult to diagnose in clinically the difference of those entities. We can see that most common clinical pictures is the neonatal biliary stasis and cirrhosis, and it can be seen in the very early state of the children, and cause of liver failures and the others liver cancers. So this liver manifestation of AT1AT deficiency is very various, but it's usually see the children, especially breastfeeding children. This is the clinical manifestations of A1AT deficiency. We see the patients with some patients only elevated liver enzymes without any manifestations. The other patient we can see patients with genotype stasis or we see that bilirubin, direct bilirubin elevations and elevated blood liver enzymes. For long run, the patient we can see the cirrhosis and hepatic failures on liver cancers. For risk factors of alpha-1 antitrypsin deficiency, we do not have the final or clear conclusions, but we see that in the patient who are elevated in the liver enzyme, we see more in males than females. In the patient who have comorbidity of the inherited disease like hemochromatosis, or in the patient with alcoholism, patient we co-affected by HBV, HCV, the progression of liver disease is quicker than or more severe than the other group. So those people we need more careful examinations and careful thorough consultations and for those patients. For the treatment, nowadays we are working with the liver transplantation or gene therapy for this patient, but without any clear prognosis yet. The other group of disease caused by A1AT deficiency, you can see more common. We see that the patient, adult patients with cause of A1AT deficiency and serum in imbalanced protease and anti-protease systems, and the lungs of the patients is chronic inflammation caused by neutrophil elastase elevations, and this is very important to protect the patient from bacterial infections and also protect the lung tissue, and it can cause this lung tissue damage, and these patients lower level of A1AT levels, it causes the patient with emphysemas. So in this kind of patient, you see more adult than in children. You know, COPD is caused by many problems, and we see the pictures of COPD caused by A1AT deficiencies may be different with the COPD caused by smoking, or because we know that the onset of COPD in the A1AT deficiency is usually earlier, and the other differences, lung damages usually occurs in the lower lobes, and COPD we caused by other causes usually see that damage on the middle lobes. For the treatments of A1AT deficiency, we can treat it by alpha-1 antitrypsin IV or nebulizations effectively. And also the COPD due to the A1AT deficiency can usually with a high prevalence in the Western countries, but the diagnosis of this is usually late even in the Western countries, because of the awareness of the doctor with A1AT deficiency is very low. The third clinical entities, this is Panniculitis. This is the same thing like in the lung tissue, due to the imbalance between protease and anti-protease. And in these kind of patients, we see that the typical lesions in the skin, in the buttock or in thigh, and can treatable by A1AT replacement. The other that is caused by bleeding disorders or the functional loss in functions of this A1AT. So this A1AT mutation in M358A. So this is called anti-thrombin 3. On this kind of patient, they call that is a Bisbert variant. Usually occurs after the accident or post operations. This patient is bleeding and maybe in some cases it can be severe enough or life-threatening. In China in 1978 they found several cases in China. So we see that is a prevalence of A1AT deficiency in the world. We see that about 1 over 2,000 to 5,000 populations. However, prevalence in Vietnam is not being studied yet. So we decided to choose children with liver biliary disease without clear etiology. So the objective of our study is carry out in 130 children with the symptoms of prolonged jaundice, idiopathic hepatitis, or with the liver cancer. We cannot, with the patient we have liver cirrhosis and hepatitis, and all of these patients are treated in National Hospital of Pediatrics. And the control group is healthy, is the same age group. So we use 3 techniques. First one, we use Immunoturbidimetric assays. We can use in the automatic biochemistry machine. We use the standard materials. We see RM46478 of IFCC. The other technique is we do phenotyping by IEF in the blood serums, in the principle of the method is changes the PE change of A1AT, because when we see that when the difference in the isoelectric levels is be difference in the greater pH gradient difference, the current pH from 4.2 to 4.9, and we can separate this protein and recognize those protein, and each electrophoresis we run is the control samples, and we see that this A1AT phenotypes and supplied by Monash Medical University. The third technique we do sequencing. These patients, we have the A1AT deficiency with abnormals in electrophoresis. We do the sequencing for the 2 exon 2 and exon 5. The results. We check the level of A1AT from 90 to 222, and we compare with the other method as authors going to think that's a similar range. We compare between the A1AT levels into subject and control group is a significant difference. We see that is the distribution of A1AT levels in the A1AT with the disease, liver disease, is it's about 11.54% in comparison to others. This genotyping by electrophoresis. We compare with standard. We see that is a PIMM. We see that it's similar like this one. This band is similar to this. For this patient number 2 and patient number 3, we think that is a homozygous. When also found the other type of other phenotyping, we see that the patient with PIMX with the standard is similar. We also found that PIMM with morphology and position of protein in bands of protein. And especially in these studies, we found that we have the different type of protein is similar like MJ. We see it as the same position, but we see the morphology is not similar like MZ, or these patients. We found that the level of A1AT is very low, 0.78 or 1.06. This is sequencing results. If you're looking for the mutations we found in the electrophoresis, is compared with the gene bank. As we introduce PIMX, which is a lower electrophoresis, we see this is a GA. We see the G become A in 1714 GA. This is an abnormal electrophoresis patients. For the other patients, you saw in the last slides, when we do sequencing, we found that we have the mutations C12781T. So that we see the tailins change to methionine. So we see the change the PI protein, and you can see the change in the electrophoresis. So summaries of the distribution of A1AT genotyping. We see that most of them is a PIM, but in our group we found some 11% of those. We see the PI'MXchristchurch and 5% PI MZbristol. When we look at the gene profile, so this is that is Professor Locos, and this is Bristol mutation genotyping. So for this type of variants, Bristol is no different to the other variants. This patient is usually have neonatal cholestasis and hepatosplenomegaly and also elevated liver enzymes. When we look at variance distribution in worldwide, we see that it's more ethnic preference. In European countries, we see that more PI, there is a PIS, PAI in Asian people. For Japanese, we see the more common ASEAMA, M mountain, and we don't see PSS or BZS in Japanese. In Korean, we in 2012 found that they have more with the SIAMA or QO Clayton. In China, we found QO Hong Kong and Bispat. And in Vietnam, we see the Bristol, and we waiting for another variants. So for the diagnosis of A1AT deficiency, due to the clinical manifestation is diverse, and the specificity is not so high. In 2003, they have the guideline from ATS, ERS. So they said that screening is needed for A1AT deficiency in high patients. In the patient with idiopathic liver disease, emphysemas, in COPD, in the damage in lower lobe, the patient with idiopathic bronchiectasis, in the patient who have panniculitis, vasculitis, or the patient with history, family history of A1AT deficiency. In order to diagnose for A1AT, we cannot just based on one platform. We need to combine many platforms at the same time. First of all, we need to check for the level AT levels. The second is phenotyping, and the third one is genotyping. Why we cannot use one platform? Because that is because due to the advantage and disadvantage platform. The first one for the levels, we see the advantage is feasible on an automatic machine, and it is not at low cost. But disadvantages, you can miss a heterozygous or loss of function variant. Why? Because we see that allele can be dominant hereditary disease. So we see that if we have the heterozygous can be not show any symptoms, or we miss chance to pick up the levels. So there's a second one is green things also, which we take the blood, but if they in a Q phase, it can be cannot find the low level of caused by generic disease. for phenotyping by IAF. The advantage of this technology is you can see almost all of the variants, but it's time consuming, and also it can be undetectable for null subtype or rare mutations. The third platform, we see that the molecular science can help us. We design find the mutations. You have two type of tests. The first one is the direct test. When we see that we suspect the patient have the mutations, we design the primers, and we can amplify that mutations. In the population we unknown of mutations, it's very difficult to use this method. The second is we use the sequencing. They have the is a better technique to find all of the mutations, because again find all of the nucleotide mutations. So with sequencing, it's a disadvantage of that is a very high cost, and we cannot do all of the exons with that SAPHINAS1 gene. So this is a diagnostic approach. When we talk about A1AT deficiency, the first is most common they do step Y. The first one is quantitative A1AT levels. If they found the abnormals, they do phenotyping. If they found the phenotyping abnormals, we do the genotyping. This real-time PCR or FLP, etc. So this way is time consuming because we need to do step by step, and we do not do cannot do this one for the screening of the community in our communities. The second approach, we do the two platforms at the same time. Quantitative A1AT levels. At the same time, they do real-time PCR, identify J and S mutations. If we have abnormals, they do sequencing to confirm those mutations. This one is applicable for the Caucasians. When we see more prevalence of mutations, so it's not applicable for Asian people, especially Vietnamese. Costly, and we need to do the sequencing of 4 exons. Very expensive. So the third approach is more suitable for Vietnamese populations. With unknown A1AT deficient variants. So we see the Christchurch and the Bristol. So other than that, we do not know. So we see that in this we do 2 tests at the same time. Quantitative ATA1 levels and phenotyping. We see those if the patient lower level with the genotyping or all genotyping abnormal, we do sequencing. This is can apply in my studies, and it showed me that it effectively. So in conclusion, so this is a new topic in Vietnam. We cannot miss because we found several mutations, especially children with high risk patient, like patient in liver disease or idiopathic disease, or the patient COPD patient younger 80 years of age, and with the recommendation of 2003 of ATS guidelines, and we need to take care of, look at closely to this patient to find the A1AT deficiency, and help for the consultation for the patient and families, and also we can have the treatment for those populations. That's all what I want to say today, and thank you very much for the attention.